One disease, many forms. Let us today uncover the mystery of cardiomyopathy. Let us define the cardiomyopathy. What is it? Cardiomyopathy refers to the heterogeneous group of myocardial diseases characterized by mechanical or electrical dysfunction, typically associated with inappropriate ventricular hypertrophy or dilation. It is basically a group of disorders wherein the electrical or the mechanical dysfunction in the heart occurs and it leads to the ventricular hypertrophy or dilation of the ventricles. What it excludes? It excludes coronary artery disease, it excludes valvular heart disease, it excludes hypertensive heart disease, and it also excludes the congenital structural abnormalities. The Harrison's Book of Medicine emphasizes the exclusion of secondary causes to establish primary cardiomyopathy diagnosis. There are three morphological pillars or the types of cardiomyopathy. Three different phenotypes, each with distinct structural or functional hallmarks. Basically, we have the dilated cardiomyopathy, we have hypertrophic cardiomyopathy, and we have restrictive cardiomyopathy. In dilated cardiomyopathy, the ventricular enlargement with impaired systolic function occurs. The heart becomes globular and weak. In hypertrophic cardiomyopathy, the thickened stiff ventricular walls, often asymmetric, there is a diastolic dysfunction which is seen predominantly. In restrictive cardiomyopathy, where the impaired ventricular filling due to myocardial stiffness, where the systolic function may be preserved. Let us see dilated cardiomyopathy in detail. Dilated cardiomyopathy, where the pathophysiology says progressive ventricular dilation, it leads to the systolic pump failure, where the systolic pump failure causes reduced ejection fraction and increased stress on the valves and neurohormonal activation. This leads to the ventricular dilation or the dilated cardiomyopathy. The etiology behind the dilated cardiomyopathy, it can be idiopathic, where the cause is not known. It can be familial or genetic, 30% cause. Viral myocarditis by Coxsackie virus B, and alcohol, chemotherapy, and toxins may lead to the dilated myocardiopathy. Let us see the clinical features behind the dilated cardiomyopathy. Progressive heart failure, where the dyspnea, fatigue can occur. Ventricular arrhythmias, systemic emboli, or the mural thrombi can be seen in dilated cardiomyopathy. Next, we have hypertrophic cardiomyopathy, where the pathophysiology says asymmetric septal hypertrophy with myocyte disarray or interstitial fibrosis, where the ventricular wall becomes stiff and hypertrophy of the walls occur. Dynamic LV outflow obstruction may occur in 25% of the cases. Etiology behind hypertrophic cardiomyopathy is primarily it is autosomal dominant disease. Mutation in the sarcomeric proteins can lead to the cardiomyopathy. Prevalence is 1 in 500. The clinical features were the exertional dyspnea, angina, syncope, risk of sudden cardiac death. Especially it is seen in young athletes. Harsh systolic murmur increases the Valsalva. The hypertrophic cardiomyopathy is most commonly seen in athletes where the person predominantly has the exercising or the hypertrophy of muscles. It's seen in most commonly it is seen in the athletes. Nextly, we have restrictive cardiomyopathy. The pathophysiology behind restrictive cardiomyopathy is it is rigid, non-compliant ventricular walls severely limiting diastolic filling. Systolic function is often preserved until late stages. Basically, it is due to the ventricular stiffness where the myocardial wall becomes stiff and it limits the diastolic filling, causing the restriction and leading to the cardiomyopathy. Etiology is infiltrative, like amyloidosis, sarcoidosis, hemochromatosis. Storage diseases like Fabry's disease, glycogen storage. Endomyocardial, where the Loeffler's endocarditis, endomyocardial fibrosis leads to the restrictive cardiomyopathy. The clinical features of RCM are dominant right-sided heart failure, ascites, peripheral edema, elevated JVP, bilateral enlargement is the characteristic on imaging. Let us see the diagnostic approach for the cardiomyopathy. First of all, we have the ECG, where the STT or the ST segment changes, conduction defects and Q waves gives us a diagnostic approach for the cardiomyopathy. Next, we have the imaging, echocardiography, cardiac MRI for the tissue can be done in the cardiomyopathy. We have the clinical evaluation where the history, the family history, the physical examination can help to diagnose the cardiomyopathy. Next, we have the endomyocardial biopsy where it is reserved for the specific diagnostic dilemma. A systemic stepwise approach ensures accurate phenotyping and guides targeted therapy. Echocardiography remains cornerstone imaging modality, while cardiac MRI adds a value in the tissue characterization, especially for amyloidosis and myocarditis. The management strategies for the cardiomyopathy, where first we have the pharmacotherapy like AC inhibitors like enalapril, ARBs like losartan, beta blockers, propranolol, metoprolol, diuretics, furosemide, SGLT2 inhibitors form the backbone of DCM management. We avoid vasodilators in obstructive hypertrophic cardiomyopathy. Device therapy, where ICDs for primary or secondary prevention of sudden death. CRTs are used for dyssynchrony with left bundle branch block or ejection fraction less than 35%. Surgical or intervention strategies are septal myotomy or alcohol ablation for obstructive hypertrophic cardiomyopathy and heart transplantation for end-stage DCM refractory to therapy. The prognostic considerations for the cardiomyopathy, where the DCM we have, it says the high risk of progressive heart failure, sudden death within 5 years, mortality up to 20% without transplant. In hypertrophic cardiomyopathy, it says 1% annual risk of sudden cardiac death, risk stratification using septal thickness, family history, NVST guides, ICD decisions. And in RCM, generally it is poorest prognosis where median survival is between 2 to 5 years. In amyloidosis and early diagnosis is critical. Next, the conclusion of today's topic, that is the cardiomyopathy, is genetic classification, shift from phenotype driven to genotype informed care, enabling the precision medicine and family screening. Genetic classification can help us to treat the cardiomyopathy. Early detection will help us to treat the patient. Screening of first degree relatives, use of biomarkers like BNP, troponin remains a cornerstone for improving outcome. Personalized therapy. Every patient has a personalized therapy like integrated system approach, combining genomics, imaging, AI, are redefining the future of cardiomyopathy and management. If you have understood today's topic, don't forget to like, share and subscribe. Thank you.